20 years ago, the Institute of Medicine report, To Err is Human, surprised the nation with its findings and set off a series of studies and activities aimed at making care safer. Dr. Mark Chassin is President and Chief Executive Officer of the Joint Commission. 20 years ago, he was a member of the IOM committee that authored the To Err is Human report. Welcome to Advancing Health, a podcast brought to you by the American Hospital Association. I'm Tom Hetterly, Senior Writer for AHA. In this Advancing Health podcast, Nancy Foster, Vice President for Quality and Patient Safety at the AHA, speaks with Dr. Chassin about the impact of the report and its effects on healthcare delivery 2 decades after its release.
Mark, thanks so much for being with us today. 20 years ago, the Institute of Medicine report, To Err is Human, shocked the nation with its findings and set off an unprecedented series of activities, studies, and events, all aimed at making care safer. Not many IOM reports have had that kind of impact, either before or since To Err is Human came out. And you were on the committee that wrote the report. At the time, did the committee have any idea that its report would have such an extraordinary impact?
No, I don't think the committee had any idea that the report To Err is Human would have the impact that it's proved to have. We were very concerned with how to get the message out to attract attention to the problems that the report delineated, but I don't think anybody had the idea that it would galvanize the nation in the patient safety movement.
And why do you think this report captured the attention and has continued to have an impact on healthcare delivery over 2 decades?
That's a very interesting question. I think there are several answers to that. The first is that, in fact, the ground had been pretty well prepared for this comprehensive report on quality and safety problems. There was a large volume of research from the previous decade, really, that documented how widespread and serious the problems were. And in fact, the IOM had a prior activity that took place between 1996 and 1998. That was the National Roundtable on Healthcare Quality that I co-chaired with then CEO of Motorola, Bob Galvin, that brought together people from a wide variety of different walks of life, from healthcare, business, government, consumer organizations, the media. And that report, which summarized the research that had been done in the previous decade, was called The Urgent Need to Improve Healthcare Quality, that was published in 1998. And I think so the first couple of points are that the ground was well prepared to have a documented report from the Institute of Medicine calling attention to the problem. And then, of course, it's impossible to ignore the semi-sensational or fully sensational headlines that the report led with, which, of course, was 44,000 to 98,000 people dying every year as the result of errors in care, certainly got the attention of the media, and then the firestorm hit.
Over the past 20 years, there have been some significant changes in healthcare delivery designed to improve patient safety, and more generally, to improve healthcare quality. What do you see as the most important change, and why is that the most important one?
The most important change that occurred immediately after the reports were published is the widespread recognition, which did not exist before, that healthcare quality had serious problems and that those problems were widespread. Prior to those reports, it was very common for healthcare leaders to say, yeah, we understand there are quality problems, but not at my place. I hire the best doctors, the best nurses. We provide the best care. Those problems exist somewhere else. And that was no longer possible. That position was no longer possible to maintain after the IOM reports were published and the lessons sank in. And they did sink in. The second big change was that recognition actually led to a large amount of resources being devoted and a lot of effort made to try to figure out how to tackle the problems and reduce their impact on the adverse effects they were having on patients across the country. And those were not necessarily, didn't necessarily have to be connected. You can recognize there's a problem and still not devote resources to it. And you can recognize a problem and throw some money at it, but not really make a concerted effort to improve. But all of those things did actually happen in the years following and early on in the years following the first 5 or 6 years following the IOM report. So those were major changes and really necessary changes in order to begin to see some progress on these very serious quality and safety problems.
Are there any efforts that you see as not yet living up to the promise to improve safety? And if so, what lessons should be learned from that attempt to improve safety, which we assume was well-meaning, but simply did not succeed?
Well, the first point I would make is that we have indeed made progress on these safety and quality problems. But at the same time, the first question we need to ask about that progress is, are we satisfied with the results? And if we're not satisfied with the results, and I don't think anybody is, we need to ask, why aren't we satisfied? And I think there are several answers to that question. The first is that quality and safety are moving targets. We are not making progress toward a static goal. And the primary reason for that is that we keep adding new stuff into the healthcare delivery system, new tests, new treatments, procedures, equipment, drugs. And each one of those new additions, hopefully, if they're well vetted, carries benefit when they're used appropriately, but they also carry risks for new quality and safety problems that we need to address, even as we have not fully assimilated safely the new products and equipment and drugs that we added last year or the year before. So that's the first recognition of how we need to make progress on safety and quality. The second is that the patient safety movement has sometimes tended to focus too narrowly on one aspect of quality, and that is the complications that patients suffer when they're receiving care. That's an important area for safety and quality, but it's not the full breadth of the quality and safety problems that were outlined in the IOM report and that continue to plague us. So in addition to complications, we need to get rid of overuse of episodes of care where there is no benefit and all that's conveyed is risk. Antibiotics for colds and simple imaging and simple back pain are good examples of overuse. We need to eliminate missed opportunities to improve outcomes by giving effective care, and that's not the same as complications. So we need to broaden the scope of how we are thinking about what the targets are for improvement. And then we need to take a hard look at how we've been going about doing improvement, because the old aphorism from Einstein applies here. You can't get different results by doing the same thing over and over again. We have to change how we've been going about doing improvement. And very broadly, we've made progress, but the progress has occurred one project after another. Hospitals and health systems have projects for reducing falls, for improving hand hygiene to reduce infections, for getting rid of wrong site surgery. But all of those make progress one project at a time. And every organization that I talk to and that we interact with tells me they have project fatigue. They can't possibly mount any more projects, but the long list of problems far exceeds their ability to mount projects one at a time. And the one-size-fits-all best practice, which is typically what we use to try to make progress, has really only produced modest improvement. And that's a really important observation that we all need to take to heart in order to make much faster improvement and of much greater magnitude. Using the one-size-fits-all best practice makes it very difficult to sustain high levels of performance, even if we achieve them, and makes it even more difficult to spread from one place to another. We have examples of new approaches to using methods that have come out of industry to improve processes. Lean, Six Sigma, change management, are producing much greater levels of improvement and are proving very good at sustaining high levels of improvement and spreading them across many aspects of the delivery system. But those are really methods that are not used widely enough. And just to give you an idea of the magnitude of the problems that we are currently dealing with, despite the 2 decades of effort to improve, hand hygiene is a good example. Hand hygiene we've known for 170 years is a really important aspect to our infection control efforts. But we see hand hygiene in hospitals failing 50 to 60% of the time, depending on the particular organization. Wrong site surgery is something we should never have to see or deal with, but the best estimates of that problem, wrong site, wrong patient procedures, are that they occur about 45 times every week in the United States. So at the Joint Commission, we have put the new process improvement methods of Lean, Six Sigma, and change management to work, partnering with healthcare organizations across the country through our Center for Transforming Healthcare to apply these tools to those kinds of persistent, resistant quality problems. And we've seen dramatic improvements pretty much with the same results across the board, whether it's falls, handoff communication, wrong site surgery, or hand hygiene improvement. And what we've seen starts to unravel the real conundrum about why the one-size-fits-all best practice is so ineffective in wrestling these problems to the ground. And the first thing that we found when we apply these tools, which systematically look for the reasons the problem exists and systematically measures the causes of the problem and which ones are most important to tackle first, second, and third, is that we find 3 findings all the time. The first finding is that there aren't just 3 or 4 reasons why there are risks for wrong site surgery or risks for patients falling and hurting themselves. There are typically 15, 20, 30, and each one of them requires a different intervention to get rid of. So that's the bad news. The good news is the second finding, which is you don't find all 20 reasons or causes for hand hygiene failure, for example. You don't find all 20 with the same frequency where you're trying to fix the problem on a particular unit in a hospital or an ambulatory care surgery center. You typically find 5 or 6 of these key reasons why the problem exists that explain 75 to 80% of the failure. So it's very possible to devise a very efficient, customized set of interventions to get rid of those 4, 5, or 6 problems. That's the second finding. The third finding is more bad news because when you apply those same 5 or 6 key interventions to get rid of those key causes at the next place you're trying to solve the problem, they don't work. And they don't work because of the third finding, and that is that the key causes of hand hygiene noncompliance, of risks of wrong site surgery, of falls with injury, the key causes differ from place to place. So you have to know what your key causes are in order to design the very efficient and effective set of interventions to get rid of them. That's what our center has been doing systematically, one problem after another, in producing generalized knowledge about what these key causes are, how to measure them in each place where you're trying to solve the problem, and how to get rid of them one at a time to great impact. So what we see when we apply these tools to those problems systematically is not 10 or 15% improvement, but 50, 60, 70% improvements within a very short period of time, just by measuring the problem, finding the key causes, and surgically targeting those key causes, which are different from place to place. We've seen those kinds of results very consistently, no matter what the quality problem that we're trying to tackle is.
Through your career as a physician, a researcher, a quality improvement leader, public policy maker, and the head of an accreditation body, you have had an extraordinary influence on care delivery, pushing for better measurement of quality and safety. Would you say a bit for us about what you see as the importance of measurement in efforts to improve safety?
Measurement is absolutely essential to improving quality no matter what the target of improvement is. You can't manage what you don't measure. That's true in business. It's also true in quality. Some of the difficulties that we've seen with measurement in quality, and I'm using that term broadly to include both quality and safety issues, some of the problems that we've seen result from the validity or the lack thereof of the measures that are used. So it's particularly important when measurement is used in public programs, whether it's accreditation, public reporting, or pay for performance, that the measures have absolutely unimpeccable and rigorously demonstrated validity. And so the Joint Commission has articulated what these criteria are. They're really pretty straightforward, whether it's for process measures or outcome measures. But we've seen repeatedly that measures that don't stand up to those criteria either lead to unintended adverse effects or are completely unhelpful in driving improvement. So let me give you just a couple of examples. In the early 2000s, when the Joint Commission began the first program to create standardized measures of quality for hospital care, we used mostly process measures. And within a few years of launching and spreading that program, we looked rigorously at the validity criteria that were necessary to support those measures, because there were a whole number of problems with the initial set of measures. We came up with 4 criteria for process measures. The first one is that we needed a large body of evidence that improving on the process that is being measured would lead to improved outcomes for patients. And surprisingly, or maybe not, there were several measures that didn't pass that criterion. Another of our criteria is that a measure in these programs must have no unintended adverse consequences and must be looked carefully over as it's being implemented to make sure that none creep into the process. So, for example, there was an early measure in the program that looked at the time to the first antibiotic in patients that were being admitted with pneumonia. Now, the problem with that is not that prompt administration of antibiotics to patients with pneumonia is a bad thing. It's a good thing. But the way the measure is constructed, you had to make the decision to deliver the antibiotic often before the diagnosis was obvious. So that encouraged a lot of overuse of antibiotics. And that measure was dropped because it failed to meet the criterion of no unintended adverse consequences. Similarly, the measure has to adequately capture the process that it's intended to measure. So we know, for example, that brief interventions in patients who are smokers are often very effective in increasing the percentage of folks that abstain from smoking after that intervention. But the measure that was in place at the time was simply a checkbox on a discharge form that said, yes, I've counseled this smoker on smoking cessation. So it was busy work without really adequately capturing the quality of that smoking cessation intervention. So we got rid of that measure as well. The criteria narrowed our measure set that we maintained with CMS during this time by getting rid of about 30% of the measures that were in that group that was prevalent at the time. And what resulted from that effort is an extraordinary and, I would say, unprecedented level of improvement in hospital performance on this large and growing body of standardized and now valid quality measures. From the earliest years in 2002, about 7% of hospitals were over 95% performance on just a small number of measures, on 8 of them. By the end of this period in 2014, 80% of U.S. hospitals were over 95% performance on 50 measures of quality of care. Not all the hospitals used all the measures, but the measures that were relevant to their patient populations. That's an extraordinary level of improvement that I believe, from my reading of the literature, is unmatched by any other effort to improve. So measurement is critically important to improvement. but measures have to meet validity criteria in order for them to drive real improvement in process and outcomes for patients. I did learn a fair amount about measurement when I was commissioner of the New York State Department of Health. We did start the first program of its kind to measure statewide risk-adjusted mortality following coronary artery surgery and then valve surgery. And what we learned first is that the measures have to be impeccably valid, as I talked about a bit earlier. And I have the scars to prove what happens when you are first in that kind of effort. But what we were able to do is to demonstrate through the validity of the measures that there were underlying quality and safety issues that led organizations to have higher rates of risk-adjusted mortality. And it's the public accountability that I think is the important component of transparency to emphasize. The public deserves measures of quality by which they can judge the performance of organizations to which they entrust their care. But those measures, as I said, have to really be rigorously scrutinized for how valid they are. What needs to be confidential is the improvement process that organizations use to drive changes in how they're delivering care in order to improve on the measures that the public sees. And you're right to emphasize the word balance, because there needs to be a balance between what the public measures show that should be transparent and the improvement efforts that go on inside an organization, which should remain confidential. That balance between transparency and confidentiality has underlain improvement in many, many other industries, and we need to achieve it in healthcare.
And Mark, similarly, as the head of an international organization that is highly regarded for its efforts to promote safe, high-quality care, what do you think is the right role for standards and accreditation in promoting patient safety?
The accreditation process has a very important role to play in guaranteeing a particular level of safety and quality in healthcare. We set very modern, up-to-date, evidence-based standards for requirements in safety and quality for the healthcare organizations that we survey. And we send surveyors out, as you know, to see whether those standards are in place, whether the compliance is adequate, or whether there are opportunities to improve. The basic function of accreditation is to set a floor and to observe that healthcare organizations are performing at least as high a level as the floor represented by those standards represents. Now, it's important to realize that while many organizations are pushing the boundaries of providing excellent care and going way beyond the standards within accreditation, there are a substantial number of organizations that are struggling even to get to that level of performance. So the accreditation process is really designed to help those organizations identify what they need to do to perform up to the level of accreditation standards. Now, we, the Joint Commission, continuously raises that floor in order to make sure that organizations are striving to do better year after year. And what we talked about before, the balance between transparency and confidentiality, plays a key role here as well. The ability of our surveyors to deliver actionable information to healthcare organizations on how they can best devote resources to improve depends on a candid exchange of information between the caregivers and the surveyors. That candid exchange depends on confidentiality, on the confidentiality of the detailed report that our surveyors leave with healthcare organizations. The public transparency part of our process is to know that the organization passed all of the requirements and is accredited. And if the accreditation status is jeopardized and ultimately removed, we inform the public about that result as well. But the balance between transparency and confidentiality in accreditation is essential in order to maintain the effectiveness of accreditation in identifying those areas where organizations need to work to improve.
And finally, Mark, as you look ahead for us, what do you think will be the most important tool or strategy for hospitals and health systems to use in their efforts to improve the safety of the care they deliver, and why?
Well, that's a big question. And the first thing I would say is that the Joint Commissions recognized that while accreditation is important and necessary, and we need to keep improving it, which we are engaged in every day, by itself, accreditation is not going to produce the results that we all want to see, which really boil down to healthcare organizations providing consistently excellent care maintained over long periods of time across every service that they deliver. In order to achieve that goal, what we've done and what lots of others are focused on is learning from industries that have absolutely superlative safety records. And by that, I mean not slavishly adopting their current practices, but learning from how they maintain those safety records and adapting those lessons to healthcare. And that's behind our long-term effort now at the Joint Commission to emphasize that leaders should be committing themselves to get to the ultimate goal of zero harm. And zero harm here goes back to what I mentioned earlier on about the broadening of the aims of the patient safety movement, broadening from a narrow focus on only getting rid of complications to also getting rid of episodes of overuse, having zero episodes of missed opportunities to provide effective care, including in zero harm, getting rid of harm to caregivers. So a broadened vision of what the ultimate goal is. Now, in order for that ultimate goal to translate into action today, what we've laid out in a fair amount of detail and now have a lot of programs and activities related to it is two twin objectives for leadership that is committed to the goal. The first is to really get the organizational culture within health systems, hospitals, and other healthcare organizations to be much more reflective of how high reliability organizations, these organizations that have achieved zero harm, how they stay safe. And they stay safe because everybody in those organizations has two jobs: the job they were hired to do and observing carefully every process they're involved in to look for unsafe conditions, to look for where safety protocols don't adequately address a particular situation that they've uncovered, reporting those unsafe conditions immediately, and seeing the organization react immediately to solve those problems, typically while they're very small and easy to fix. That organizational culture depends in healthcare organizations on getting rid of two big problems. The first is getting rid of disrespectful and intimidating behavior that really characterizes too much of the workplace in many healthcare organizations, and that requires a direct and concerted effort. Parallel to that is an effort to, again, emulate high reliability organizations by not only having people feel free to speak up and report unsafe conditions, but also holding everyone accountable for consistent adherence to all of the safety processes and protocols that we have to help our patients stay safe. And then, going beyond organizational culture, we need to recognize that in healthcare, we have a set of circumstances that don't exist in commercial aviation, in commercial nuclear power, in amusement parks that are safe. And that is, we have safety processes that fail 50% of the time or more in hand hygiene compliance, in failures of handoff communication, in many other areas. We need to deal with that magnitude of safety problems very differently from organizations like commercial aviation, which rarely even have close calls, let alone adverse events. And that's where the new process improvement tools that we've been talking about, Lean, Six Sigma, change management, that's where their role is. They can make improvements of 50, 60, 70% in processes in a very short time period when they're applied correctly and sustained. That's the answer to the situation that we face in healthcare of low reliability. Another aspect to how we, I think, need to deal with this set of quality and safety problems is by creating a much different and better partnership between government and private improvement organizations. And here we can learn a lot from commercial nuclear power, which has created exactly that kind of partnership. In commercial nuclear power, there is a federal regulatory agency, the Nuclear Regulatory Commission, which has very similar functions to CMS in healthcare. And they have a counterpart in the private sector called the Institute of Nuclear Power Operations, which is a not-for-profit 501c3, has a lot of characteristics similar to the Joint Commission. And what those two entities have negotiated over the years is a formal written memorandum of agreement where each recognizes that the other has strengths that it doesn't have. And it clearly outlines which activities are left to INPO, the Institute of Nuclear Power Operations, the private organization, and which are NRC responsibilities. So INPO, like the Joint Commission, sets standards for safety in nuclear power plants all across the country. It sends survey teams out to inspect those organizations to make sure that all of those standards are being met. It drives improvement with confidential reports that are not public to those nuclear power plants and observes the improvement that takes place. There is a confidential reporting system for problems in safety that both NRC and INPO get, and it's a very well-functioning division of labor, if you will, that we need to emulate in healthcare if we're going to take advantage of the strengths of private improvement organizations like the Joint Commission and others, and government regulators, public regulators like CMS. Improving that partnership, getting it closer to where the nuclear power industry is, would make a great deal of progress toward a much more effective quality oversight process for American healthcare.
Mark, thank you so much for being with us and for providing such important information for our listeners. Truly appreciate the work that you have done and the work you continue to lead to improve quality and safety throughout the country.
And thanks, Nancy. I really appreciate the opportunity to reflect a bit on the last 20 years since the IOM reports were published, the opportunity to look a bit into the future. And we're always happy to continue the conversation about how to improve safety and quality for the American people. Thanks very much.